My name is Chase Robinson. I'm president of the Graduate Center, and it is a privilege. One normally says a pleasure, but in this case, I'll just say a privilege to welcome you to today's discussion. Now, the hard work of organizing today's discussion, I think, fell principally to Don Robotham, who's the director of the Advanced Research Collaborative, thus the signage, the ample signage out front. Don, in this and many other respects, does many things that fall outside of his job description, and I'm personally indebted to him for taking the leadership that he has in this. The hard work, although there might be a bit of pleasure mixed in, of moderating today's discussion falls to Leith Mullings, who is, as many of you will know, a distinguished professor of anthropology, the past president of the American Anthropological Association, and someone with very considerable research indeed, lots of expertise in health inequalities, both in Africa, globally, West Africa in particular, but also locally, Harlem. We are no strangers to health inequalities here in New York City. So those two names, but in fact, of course, we're joined by three very distinguished speakers, and I'll leave it to Leith to effect those introductions. But thanks to all of you whom I've mentioned, and perhaps scores others whom I have not. A very, very quick word from me. What we'll be learning about today, of course, is a humanitarian crisis. It's a humanitarian crisis that some would describe as taking place a world away, a crisis in the sense that well, at least according to what I've read recently, mortality forecasts, somewhere between 20,000 and 100,000. But I said that some might reckon that these events are happening a world away. But of course, in this era of globalization, of compressed time and space, it is nonsense to speak of events taking place a world away. There are about 50,000 West Africans living in New York City. This community itself has students from Nigeria and the Ivory Coast. We have many faculty who do research in West Africa. The Graduate Center is part of the large organism, that enormously vibrant organism known as the City University of New York, which has a population, if you add its students, its faculty, and its staff, over 700,000, exceeding that of the city of Boston. So what does it mean in this era of globalization when one witnesses events taking place as distressing as these? Well, it seems to me we can do at least two things. First, we can learn, and that's the prospect that is before us today. We can learn about, how would I put it, the intertwining of issues of development, poverty, globalization, violence, epidemiology. That's one thing we can do. The second is that we can give not only of our intellectual energies, but of our resources. We can look after our neighbors. It is a source of some consolation that representations that my office made have been accepted, and a really terrific charity, Global Impact, will be counted in this year's CUNY campaign. So when you all receive, and those of you who do not receive it, do tell me or Dawn or Leith, when you receive notice of the CUNY campaign, which will be the next few days, Global Impact is the charity which can make some resources available so that, at least in the short term, we can do a few things to remediate, to mitigate at least some of the problems. So without further ado, I'd like to turn the microphone, if not the podium, over to Leith Mullings, and to get today's discussion started. Thank you all very much.
So welcome to all of you, and thank you for coming out to discuss this very important issue. I'd like to give special thanks to President Chase Robinson for his support and commitment to all kinds of issues, but this one in particular today. I'd like to thank Professor Donald Robotham, Director of the GC's Advanced Research Collaborative. Donald Robotham initiated and developed this important project. Professor Funke Akome of Brooklyn College and the Advanced Research Collaborative, and Alida Rojas of the Advanced Research Collaborative, both of whom worked very hard to make sure that this would happen. As we meet, a major health crisis is confronting the world. We are contending with the largest and most deadly outbreak of Ebola since it was discovered in 1976. In the West African countries of Guinea, Liberia, Nigeria, and Senegal, more than 5,300 people have been infected with the disease, and over 2,600 people have died. Among them were 300 health workers, and over half of whom died. As scholars, we encourage all immediate emergency measures to stop this deadly epidemic. But we also turn our lens to the broader social forces that are embodied in increased risk. A popular explanatory framework in the West generally emphasizes weak governance, lack of adequate infrastructure, and poverty. While this is often true, in order to make serious long-range interventions, we must ask, as scholars, how this came to be. We must look, for example, at the structuring of postcolonial borders and how they influence a range of issues, including civil wars. But more recently, and more critically, we need to examine the effects of the policies of international organizations such as the IMF and the World Bank, and the ways in which the policies of structural adjustment pressured these countries to focus on debt repayment, attracting foreign investment and privatization, and actively discouraging them from investing in public infrastructures such as health systems. We also have the responsibility to address the issues around race, nationality, and demonization. These issues too often appear as an undertone in media representations, similar to HIV, AIDS, and Haiti. And as a perhaps subconscious undercurrent in much of Western thought, the issue of, it influences the issue of who is treated and who is not. In other words, we seek to understand the broader economic, social, and cultural context in which health and illness occur. And today, we are fortunate to have three panelists who will help to guide us through this broader context. And we will follow, they will speak for 20 minutes, and that would be followed by opening the discussion to the floor. And if anybody wants to sit, there's some seats up here. You don't need to stand. Okay. The first speaker will be Stefan Helleringer, who is a social demographer. He's interested in the measurement of global burden of disease and associated risk factors, as well as design and evaluation of programs addressing health issues in low and middle-income countries. He has worked in Senegal, Ghana, Nigeria, and Malawi, and his research has been funded by the National Institutes of Health, the World Bank, and the United Nations Children's Fund. The title of his presentation is Ebola by the Numbers, Not a Small-Scale Killer Anymore. The second speaker will be Kim Yi Dion. She's an assistant professor of government at Smith College, where, among other subjects, she teaches courses on African politics. She's been a Fulbright scholar and has conducted research on HIV/AIDS in Malawi, Ghana, and Tanzania. Much of her work focuses on the opinions of ordinary Africans about life improvement interventions and the relative success of such interventions. Her work has been published in many journals, such as African Affairs, Comparative Political Studies and World Development. And she will speak to us about the challenges to the Ebola response. Adia Benton is an assistant professor of anthropology at Brown University who has worked and lived in various parts of Africa with long-term experience in Sierra Leone. In addition to her interest in science and technology studies and political and legal anthropology in Sierra Leone, Nigeria, and Mozambique, she has studied the impact of public health, humanitarian, and medical interventions in communities. Her research has spanned such topics as HIV/AIDS, essential surgical care, post-conflict development, and gender violence. And her talk is entitled The Ebola Crisis, Anthropological Perspectives on the Outbreak and Response. So let's begin with Stefan Hellinger.
Okay, well, can you hear me? Yes. So thanks a lot for having me. It's a pleasure to talk, unfortunately, about a pretty tragic topic these days. And what I'm going to try and do today is look at some of the data that has been coming about this Ebola outbreak to try and understand what are some of the reaction to these numbers, to the scale and magnitude of the outbreak, and how ultimately that may determine the scale of the response to this particular outbreak. And the first thing I should say is that this outbreak of Ebola in West Africa is really a first, because previously, prior to that outbreak, occurrences of Ebola have been vastly limited to areas of Central Africa. And earlier, towards the end of 2013, Ebola actually emerged in Guinea, so in the area circled in red there, a place where it had never been seen before. And since then, the outbreak has basically proceeded in two phases. First, we've seen a number of cases appear in Guinea, which is the line that goes up first on the graph on the right of the screen, and the outbreak starting to spread in that particular country. And then in late May, at a time when the public health authorities in Guinea and in other countries, and probably the WHO also thought the outbreak was getting under control, we've seen the number of cases rapidly take off in two other countries, in Liberia and Sierra Leone. And since then, the progression, the number of additional cases has been growing extremely fast in those two countries. And if we compare this, the magnitude of the outbreak today to historical outbreaks of Ebola, which are represented by size on the graph on the right, it's completely out of the proportions that we had gotten used to, because it has already infected in those three West African countries more people than Ebola had infected previously during all the outbreaks that had occurred. So it's really already an historic outbreak. Now, with this in mind, however, despite the fact that by Ebola standards this is an historic outbreak, the data that we have about this outbreak has elicited three types of reactions in the broader public. The first, and during this talk I will review all these three types of reactions and try to debunk them one by one. The first one, which is primarily something that has been a concern in Western countries, in the US, in France, in the UK, for example, is that, well, this might well be the next pandemic and that the whole world is at risk and that we should be very concerned about Ebola coming here, to New York City, to Paris, and so on and so forth. Different view on this outbreak, on the other hand, has been quite the polar opposite to this reaction, and has been to say that, well, this outbreak of Ebola may be the biggest outbreak we've ever seen, but it's still a small-scale killer. It still affects only a small number of people, and we shouldn't let this distract our attention from the real big killers like malaria or HIV. Okay, so that's another perspective on this outbreak. And finally, a third attitude towards this outbreak that we see percolate through the media in particular is that, well, even though this is a terrible outbreak that affects already a large number of people, it is especially dramatic because it comes with collateral damage. And so it may kill only a small number of people, but it causes much more deaths and damages by the disruption it causes to social life, economies, health systems, and so on and so forth. And we should worry about this outbreak because of these other consequences rather than because of the death toll, the direct death toll of the outbreak. So I will go through these different types of reactions and try to confront them with the data that we have on the outbreak itself and on other aspects of health in the affected countries. So first, Ebola as the next global pandemic. As I said, this is a concern that's generally focused on the potential for exportation of Ebola cases from West African countries to the US, UK, France, etc. And it's generally followed by concerns about which prevention measures we should adopt to make sure that no cases come here. There's been all sorts of debates about preventing travel, grounding flights, increasing screening at airports, increasing various other measures that may prevent the importation of Ebola in Western countries, which have been discussed. But if we look at the data, and some folks in the mathematical modeling community have looked at this in particular, what are the risks for exportation and spread and subsequent spread of Ebola outside of the three countries that I've talked about before? So, for example, there's been a recent paper by Vespignani and colleagues that has tried to model this potential for international spread of the disease by looking at patterns of travel between different countries, including flights and other modes of transportation. And what these models suggest is that, yes, there is a possibility that more countries will be affected by the outbreak, especially as the epidemic in West Africa grows. But generally, the outbreaks that will result in those exportation countries will be fairly small. So, for example, the plots here represent the expected sizes of outbreaks in the event of an exportation to these particular countries. And if you look, for example, at the United States, here you see that in the event that there is an importation of Ebola in this country, it will be contained and will be limited to a very small number of cases. Okay? And that is already something we've seen to some extent happen in Nigeria and Senegal, which are two countries where exportations have taken place. And so far, fingers crossed, it seems like there hasn't been significant spread within those two particular countries. So the potential for this to become the next global pandemic that's just going to sweep the world, like in Contagion, for example, appears to be relatively limited based on models. Okay, so I'll move on to the second attitude towards the growth of the outbreak, which is one that considers Ebola as a small-scale killer, and it's something that we've seen a lot in the press. So here I've tried to put a few titles that are of articles and opinion pieces that have been published in various outlets. So, for example, The Guardian ran something about, if you're concerned about Ebola, you're worrying about the wrong disease. Forbes mentioned that there are far higher public health priorities for Africa than Ebola. And just last week, just a couple of weeks ago, the Washington Post had this paper about how Ebola is actually stealing attention from diseases that kill a lot more people. Okay, so it's this big attraction grabber, and when in fact there's very little, when in fact it pales in scale compared to other diseases. And this type of discourse, opinion pieces, is usually accompanied by frequent comparisons between the number of deaths caused by malaria, HIV/AIDS, and other diseases that are endemic in sub-Saharan countries and the actual Ebola death count. So, for example, people often point out that in Africa as a whole, malaria causes as many deaths every 2 days as Ebola has caused since 1976, so since the first recorded outbreak. And even at the level of affected countries, for example, it seems like you can see on the right here, which is a graph that was published in The Economist in August. Well, Ebola looks like it's dwarfed by other causes of death. So, for example, here that graph shows that Ebola in the 4 countries that were affected in August, Sierra Leone, Liberia, Guinea, and Nigeria, Ebola causes approximately 4 deaths per day versus more than 600 due to HIV/AIDS. So in that case, the comparison is fairly straightforward. So all of this to say that a lot of folks out there argue that Ebola steals all the attention from these other diseases. Some people have even called Ebola the Kardashian of diseases, something that's very telegenic, but in the end isn't that relevant. So we shouldn't focus our attention too much on these particular diseases. Well, I take a lot of issues, and some of my colleagues also, with this particular view, because it rests on 2 misconceptions and ways to compare causes of death in different countries. In particular, there's a geographic fallacy here, comparing Ebola, which spread in only 3 countries, to the burden of disease at a continent level. That's probably not the best way to assess the importance of Ebola in context. And the figure from The Economist, for example, also included Nigeria, which is a country where transmission of Ebola has not been established. The outbreak has not percolated within the country, and it's a huge country, so it looks like the distribution of death is biased towards what's happening in Nigeria. And the second issue we have here is a temporal fallacy now, in the sense that these comparisons that are conducted at one point in time ignore the fact that this outbreak of Ebola is still unfolding, and this is still a developing outbreak, and the low number of deaths now may have nothing to do with the count of deaths that are coming as the outbreak is spreading within the population. So the situation in 10, 20, or 30 days may look wildly different. So we need to take those 2 dimensions into account to assess the real burden of Ebola in those specific countries. So that's what we did. We focused on the country where the virus is spreading, and we compared them to available data on mortality from other causes of death. So unfortunately, there aren't up-to-date data on mortality from other causes of death in those countries, so we have to go back to pre-outbreak data from the World Health Organization or from a study known as the Global Burden of Disease study. And what we see from this data is that Ebola in the country that it affects, for example here the case of Liberia, is already a massive killer. Here we plotted the number of deaths per day in the country due to various other causes of death, and we plotted the number of deaths per day due to Ebola based on the WHO count. And since the beginning of the outbreak in Liberia, so since the end of May, the average number of deaths per day is much higher than what we had come to expect from the other causes, including malaria, including respiratory infections, and so on and so forth. Since September 1st, it's even worse. Since September 1st, the WHO has recorded 42 deaths per day in the country. Soon enough, we're going to need an entirely different scale to plot the death rate the daily death rate from Ebola if the increase continues at this pace. Okay. Okay, so where we stand now in Liberia, we've recorded 1,459 Ebola deaths. So how does that compare to yearly totals that we've come to expect? It's already more than yearly totals of road traffic deaths, more than maternal deaths in the country, and it's comparable to diarrheal diseases. But if we extrapolate just a little bit the growth of the epidemic and we try to see where things might be headed, we will see very rapidly that Ebola might become the leading cause of death in the country this year. So not a small-scale killer by any means. And this is what I've plotted on this particular graph, where the blue line, as you see here, these are the recorded Ebola deaths in the country. So it's plotted on a logarithmic scale, which means that the increments are scaled by multiples, not a fixed amount every increment. So this is the recorded number of Ebola deaths. This, on the other hand, the dotted red line is the extrapolated epidemic growth. So I've just extended the line, the growth of cases and deaths here. And what we see from this particular thing is that at this pace, by October 12th, Ebola will have overtaken the previous total of malaria deaths in the country according to the WHO, which is the lowest estimate we have for malaria deaths in the country. And by November 10th, it will have overtaken the highest possible estimate of malaria deaths in the country, because there's a bit of uncertainty as to how many malaria deaths there are in the country in any given year. So you see that very rapidly Ebola is going to become the leading cause of death in Liberia if the outbreak continues at this current pace. So not a small-scale killer by any means anymore, at least in that particular context. So how bad can it get then? That's one question that's on everybody's mind, and there's been quite a large number of more refined projections, things that are a little bit more thoughtful than what I've just done about extrapolating a line, and that are based on an understanding of how epidemics function. And so these models are based on what we call exponential growth patterns, in which one infected case is probably going to infect one or more other people, and so on and so forth, and the epidemic grows like this in an exponential manner, fairly fast. And so these models now project various scenarios. Some of them are limited to 20,000 more cases by the end of the year. Some of them reach all the way up to 275,000 cases by the end of the year in those three countries combined. So some of the more recent models that have come in over the last week. So if you compare that to the total number of deaths in those countries prior to the outbreak, we had come to expect about 215,000 deaths in those countries in prior years. And so if you relate that to the upper bound, for example, 275,000 cases, that may translate it into 150,000 deaths or something like this. So it's really a huge magnitude by the local standards in terms of mortality costs. Okay. So now we come to the final attitude about the final perception about these numbers is that, well, that outbreak matters, but also what matters more than the outbreak itself is the collateral damage. And you will have seen a lot of popular press, for example, say things like, you know, why most of the people Ebola kills may actually never contract the disease, how Ebola can kill you even if you don't have Ebola, and with Ebola crippling the health systems, Liberians die of routine medical problems. So that's a very valid concern, that the disease itself doesn't just cause mortality by infecting people, but also by shutting down hospitals and preventing people from accessing care. And so there's a view out there that says that, well, this kind of collateral damage is probably should be more of a concern than the outbreak itself, and that we should try and focus on these other deaths and broaden the focus of the response, for example. Now, the problem with this and trying to find out whether the collateral damage will be bigger than the direct death toll of Ebola itself is that we don't know very much about the collateral damage because of very weak information systems in those countries and very weak vital registration system. So all we know is that there's been some recent report from the Liberian Ministry of Health describing lower utilization of health services. For example, pregnant women attend antenatal care much less often than they used to before the outbreak. But we don't know how that translates into higher mortality because there's no real-time data on these mortality trends. All the real-time data on mortality that we have from this country is the count of Ebola deaths. We don't know about other diseases. And also, there are various aspects that lead us to believe that the collateral damage may not be as large as we think based on the closure of the hospitals. First of all, because the outbreak doesn't just affect the utilization and the functioning of health system, but it affects a broad range of the aspects of social life, including, for example, aspects that may be detrimental to health, like increased food insecurity, but also aspects that may be protective of health. People tend to have reduced contacts between each other, and at this point, maybe respiratory infections may spread less efficiently. There may be increased hand washing and sanitation. There may be reduced mobility, and so on and so forth. All these that may affect the health and survival of population. And also, something that we see quite often in demography, and something that we see in particular in the context of demographic crisis, mortality crisis, is that when a new cause of death, like Ebola, erupts in a particular country, it actually mechanically reduces the number of deaths due to other causes, because it will kill people who may have died from these other causes if Ebola had not affected the country, for example. So this is, for example, something that you see during heat waves or during various other mortality crises, where you would expect a very large impact of the crisis on the overall mortality, but in fact it's mitigated by the fact that some of the folks who die during an outbreak actually may have died from other causes before. So in the end, the overall net sum of the collateral damage may not be as large as we think it is going to be. And in conclusions here, I would just like to point out that, well, first, the reactions to the growth of the epidemic in West Africa have often tried to put this Ebola outbreak in perspective, or kind of minimize its magnitude in comparison to other diseases, or to emphasize its consequences, whether they are about the collateral damage or its consequences on the economy. And based on the epidemic trends and what we see unfolding now, I think it's high time to focus the debate instead on just preventing a huge death toll from the outbreak itself, rather than worrying about what the outbreak may cause. I think what the data tells us is that this is spreading fast, and this will affect a large number of people unless something happens directly. So that's where I'll keep this here. Thank you.
Great. So thanks, Stefan, for putting everything in context. I really want to thank Don for inviting us. I know that he's been following the events closely, and it was really important to him that we have something, I guess, akin to a teach-in, right, to try to learn about what's going on and try to raise awareness in a way that's useful. And part of that is, I think, mostly in response to what we have been reading in the media, even otherwise responsible journalists. And so what I'm going to talk about today are the challenges to the Ebola response. And what I want to say, what I want to preface what I'm going to say today with is that we're going to know a lot better years from now what the real obstacles were. And so some of the things that I'm going to talk about today it's to the best of my knowledge. And it's really about raising some questions and seeing some patterns, especially given what we know from previous epidemic outbreaks. So, my mom said that I was always the kind of person who raised a lot of questions and caused a lot of trouble. And so that's actually what my goal is here today. So we'll see if I can accomplish that. So what have been the challenges? In particular to this outbreak in West Africa. And part of it is, as Stefan had said, we didn't have a recorded previous outbreak. Now, actually, there's some new data that shows there has been previous exposure to Ebola before in some of the areas that were affected, but it never reached a critical mass such that there was this incredible outbreak, right? And so one of the challenges then is just not having experience with how to deal with the disease, right? So if it's not something that you've experienced, right? I mean, just think about how Americans responded to the 2 Americans getting evacuated to the US, right? I mean, all sorts of people went crazy. And part of that was just not having ever had someone with Ebola in the country before. People didn't know how to react, right? And so governments in these countries, healthcare workers in these countries have not faced this problem before. And so their ability to respond to it is going to be constrained. And in particular, this outbreak started at a border, right? So it started at an area that's kind of on the fringe, right? Far away from the reach of the state, where the state isn't providing much in the way of public services, and where the border is rather open with other places. And so then we see it spread initially, right? If we look at kind of this, so this is a map that just shows the intensity of Ebola spread. And if you can see kind of in that crux, right, in between those 3 countries, that's really where Ebola has hit the hardest, especially early in the disease. And so when you have people who frequently move across borders, right, people marry across borders, people have friends across borders, people have jobs across borders, people trade across borders, right? And so whenever you have an outbreak where there's this kind of mobility around the borders and there's not a strong presence of public provision of social welfare, it's going to be hard to respond. Now it's not one country making a decision about what's going to be done. Now you've got 3 countries trying to decide what to do. And even if one of them does a really bang-up job, the other 2 could be terrible. And again, people are going to go across the border. So you need something that's actually going to work across the 3 countries, right? You need some sort of coordination, right? And that has been particularly difficult because in each of the countries we have a very weak health infrastructure. So in any one country, it's going to be a challenge to respond because any one country has a weak health infrastructure. And I'm just going to go back to what Leith brought up earlier, right, that there's this legacy of structural adjustment policies that led people to not invest in health, right? And it's really interesting to me. So when I talk to friends about this who don't study health or don't know much about Africa, they're like, why aren't they spending more on health? Why don't they send more people to medical school? I feel like I want to say, because we told them not to, because we stopped giving them any sort of money that was due them because we made all of these rules that they shouldn't. And it's not just structural adjustment policies that affect investments in health. It's also the imposition of elections. Now, I know everyone likes democracy and elections are good, but as someone who actually studies politics, I'm not convinced that actually elections are good, at least not in the long run for public health, right? So some of my research, on another response, on response to another disease, right, on response to AIDS, was that people who thought they would be in office for a long time were much more likely to invest in health, right? But what is the problem that's introduced when you have regularly timed elections? That you want to be competitive, because that's real democracy, right? So then you have people who are in office who are working really hard to get themselves reelected, right? And building hospitals that in the long run will extend life expectancy for your population does not get you more votes, right? That's not how it works. That's not, and you know, there's other research that shows that democracy is really good for health, right? But in particular context, right? If you bring the population of the country cases down to, you know, just limiting yourself to looking at African countries, democracy isn't necessarily good for health. Certain kinds, at certain times, in certain ways, it can work. But we have to think about the broader context in which a lot of these governments are operating, and those are the rules that are made in corridors of power, right? Not necessarily of their own volition. And so what you see, the result of that is a lack of capacity to respond. So this is actually a map that came out of a recent WHO document about the capacity to respond. And, you know, so these different letters, right? T is whether or not there's a treatment center in these specific localities where there's an Ebola outbreak, right? R is whether or not there's a referral center. L is whether or not there's a laboratory, right? Green means good, it's functional. There's a treatment center that's functional, right? You don't see very many green T's up there, okay? Whether there's a laboratory, right? How many green L's do you see up on the map? Not many. And what it means then is, you know, for example, in Monrovia, you can see quite a bit of red, right? They don't have the capacity to treat, refer, or take labs for people. In Monrovia, actually, the capital of Liberia, this is where Médecins Sans Frontières has estimated there's a need for 800 beds just to take care of the people that are known to be sick right now, right? 800 beds. There's just not enough capacity to respond. And then, of course, you know, what happens, right? We decide that there's supposed to be some coordinating body. There's supposed to be someone who's going to rally the troops and get us all to do something. And we thought that would be the WHO, right? Because health is in the title. And so, you know, a lot of people just expected, you know, that's what they're supposed to do. But as my colleague Jeremy Yude, who actually studies the World Health Organization and global health governance more generally, has shown, there's been serious defunding of the WHO. And they don't have the capacity even to respond. Granted, they have, I hear, very nice offices in Geneva that maybe, you know, if they cut back a little bit on their rent, they might have some more money to do other things. But their response was initially slow, right? And more generally in the international community, the response was not necessarily about, you know, how do we take care of the people who are sick, right? The response was, how do we protect ourselves from getting this deadly disease, right? How do we keep it from crossing our borders, as Stefan had pointed out, right? So what little response there was mostly focused on those of us who live in Western countries, right? Who have an excellent healthcare system for the most part, right? And let me just show you this in a timeline of events. Okay, so we get an announcement of the Guinea outbreak in late March, right? So the first infection we know, the first infection that we know of, we think, died in December, but we don't actually know about an outbreak until March. And then shortly thereafter, we hear that there are 2 cases reported in Liberia. And then in May, we get the first confirmed case in Sierra Leone, right? So by end of May, we know it's in 3 countries, okay? But we start to see in May, as Stefan had mentioned, that the WHO and maybe others started to feel like, you know, maybe things are getting okay, and their response wasn't as aggressive. And it's not until August 8th that the WHO declares an international health emergency. Right? So it's in 3 countries at the end of May, and it's not until August that it's declared an international health. And not to say that doing that actually does anything. I'm sure somewhere it's supposed to flip some switch. I haven't seen how what impact that has brought. And then on August 12th, there's a UN special envoy appointed, right? What do these guys even do? I don't know, right? But that's our response, right? We're going to appoint a special envoy, and I'm sure they go on a fact-finding mission, right? Like they couldn't find facts in June or July, right? there's all this time that's passed. And here we are mid-September, and President Obama announces a plan that's going to cost about $750 million, that's going to involve 3,000 troops. Right? In September, right, in mid-September, does anyone know what happened in between the May and the August? What happened in between there? You get Americans getting sick, right? Late July. Late July. I should say you get 2 white Americans sick in late July. And then now it's an international health emergency. Now we need a UN special envoy. Now we're going to have this $750 million plan with 3,000 troops. I don't even actually know. I keep trying to do the back of the envelope calculations of how that $750 million is going to be spent. It's not clear. Oh, and then of course a couple of days later we get UNMIR, right? The UN mission for emergency Ebola response. Right? This was announced during the special convening of the UN Security Council and was unanimously adopted. Yeah, I don't know what they're going to do, right? All of this stuff that's going on. There have been a lot of commitments made, right? And we've had that over the course of later in the outbreak, and I still don't know who's leading, right? And I'm actually trying to find out, right? I'm not just someone sitting watching CNN where they just show people in airports. But I can't actually tell who's in charge. And I think that that's really important. If we think about how to contain epidemics, in political science, we talk a lot about game theory and how everyone's actions are dependent upon how other people are going to act. And there's this notion of shirking, right? France has got Guinea, so we're not going to deal with that, right? They'll be fine, right? And France may think, oh, the U.S. has Liberia, we don't have to do anything for them, right? And I don't know if there's much urgency in thinking about this kind of at a broader scale than picking countries that used to be your colonial legacy. Okay, so to talk about exponential projections, I'd just like to talk about the international response about how much money was needed, right? So in mid-April, the WHO says we need about $5 million. Give us $5 million and we're gonna tackle Ebola. It'll be done, right? Okay. Then end of July, the WHO says, actually, we need $100 million. And we're not asking you guys for $100 million. We're just going to ask you for about $73 million. We'll get the other $30 million from the 3 countries that are most heavily affected. So we're just asking for $73 million. And right after the WHO says this, the World Bank says, we're giving you $200 million. So I don't know, was the World Bank just really slow at cutting the check? Because now, in that same announcement of the establishment of UNMIR, the UN Secretary General now estimates that we need $1 billion for the response. So I get that the number of people affected, I get that it's gone up. But I'm just wondering, how much is it going to be next week? And is it ever going to be enough? And is it because they're too slow at spending the money? I don't know why, they met each of these each time, and somehow it's still not working. And I'm not opposed to spending the money, right? And it's all for a good cause. If it is all going to the cause and people are actually getting treated, right? If people are actually going to be kept safe from getting infected. I'm not really convinced. And part of my skepticism about what we're going to do is what are we supporting, right? So there are things that haven't worked, right? So these pictures were taken during a quarantine in West Point, a densely populated neighborhood in Monrovia. And that didn't work, right? There was 10 days of not letting people leave the neighborhood. That didn't stop people from getting sick. That didn't, I don't actually know what that did, except, get a lot of people upset and get one young man killed for trying to leave the barricades, right? So here's some more collateral damage that we don't think about, right? So that kid didn't die of Ebola. He died, were Ebola not there, he might have lived, right? And then, of course, some other actions taken by local governments. The Liberian and Sierra Leonean presidents had made threats of prosecuting anyone harboring the infected, right? This is all theater, right? We're not going to actually do anything, but we're going to say we're going to prosecute people, right? We're going to quarantine neighborhoods with soldiers and police, right? Because we don't have a healthcare system, we're going to use the one thing we do have, right? And that's force. Okay, and it may not actually have any impact on public health, but if you've got a hammer, everything looks like a nail, right? Another thing that hasn't been working is closing borders and suspending flights, right? People thought, okay, you know what? You people have Ebola, we're just gonna close the gates. Nobody's gonna come in from that side and we're gonna be fine. Well, that didn't work out so well, right? So there's this recent story of these two Dutch doctors, right? They don't seem to be infected with Ebola. However, they were exposed. And what's interesting is, despite various border closures and restrictions on travel, they had no problem going 900 miles overland despite having been exposed to Ebola, because they needed to get evacuated, right? So they went from, was it Sierra Leone or Liberia?
I hope it's from Liberia, but
Liberia
another country.
to Ghana, right? To ring the bell at the Dutch embassy, as they say. And what if they were sick? What if they actually had contracted Ebola, right? Who would they have infected in the trotros that they rode in to get to Ghana? It doesn't always work. And suspending flights, that's making it difficult to get people there. It's these are having really, really negative effects on the economies, on the local economies. Not just flights and borders, but also shipping routes, like not letting certain ships go into Cote d'Ivoire. Right? People are canceling their safaris to South Africa. I mean, come on, it's ridiculous. Brazilian businessmen have canceled a meeting in Namibia. Namibia, right? If you know the map, it's so ridiculous. And that doesn't stop the spread of Ebola, right? Okay, so what is working, right? Where's the upside? So this is a photograph promoted on the WHO's Facebook page of residents in Freetown in Sierra Leone during the house-to-house Ebola talk campaign, also referred to as the 3-day lockdown, where people weren't allowed to leave their homes. And look, everyone's happy. So it depends on who you ask whether this is working, right? So the Sierra Leonean Ministry of Health and Sanitation released a press release before the 3 days were up, in fact, to say that they had reached 75% of Sierra Leoneans during their house-to-house Ebola talk campaign. And so they think of it as a ringing success. We can't get more details on how many patients they identified, how many of those were actually given treatment, right? So there's all these other metrics that I would be interested in knowing more about before calling something successful. But I don't know. People I respect have been very positive about the campaign. So I'm keeping my mind open, which is rare when it comes to these kinds of things. So what's interesting is there's this common statement from folks in the West saying we know what works. President Obama said it more than once, right? You just gotta get people in the hospital and taken care of and isolated, right? That's all you gotta do. No big deal, right? Okay, so what do we have to do to make that happen? If we know what works, everybody, if we know that if anyone were ever infected here, it would just be, like, nobody would get it, right? We'd contain it. You know, look at what happened in Senegal and Nigeria. Okay, so why aren't we doing that? If we know it works, then how come our people are still getting infected? It's really arrogant to me to hear this. Like, if we know it, if we all just have the solution, then why isn't it working? And part of that is that, you know, here, where we would never have an outbreak, we provide protection for our local healthcare workers, right? We pay them, usually on time. We evacuate them when they get sick, right? How many health workers who are Sierra Leonean or Liberian or Ghanaian nationals have been medically evacuated to a country with excellent healthcare provision, isolation units, and around-the-clock, well-treated staff? Really, I want to know how many. I can't find any. 4 Sierra Leonean doctors have died of Ebola. At the same time as these 2 Dutch doctors who may have been exposed but were never tested positive, they get medically evacuated. And here's the 4th doctor, Olivet Bach, is sick. Germans are ready to take care of her, and the WHO says, sorry, we're not footing that bill. Everyone keeps talking about sending more doctors, right? USAID has this call for doctors. Even places that I like Partners in Health is calling for more doctors. And I get that. These are places that have, you know, limited health infrastructure. They have very few doctors per 10,000 people. But there are local health workers there, and they have been amazing, and we have not been supporting them. And that's part of the problem. We're not willing to pay their salaries. We're not willing to evacuate them when they're sick, right? What does that say to them, right? We're just going to bring our own people in that we're willing to fly back out. I don't know that that's going to work. So I'm out of time, but I hope this raises some questions that we can talk about in the Q&A later.
Thank you very much.
Thank you so much. And thanks, Kim, for giving the talk I don't have to give, which would have painted me as angry. So we can't have enough of that. So I'm going to do something that I'll start with a quote from one of my anthropology foremothers, Mary Douglas, and she says that the learning of exemplars is part of the process of constituting a community. And that's from her work, The Rightness of Categories. And in this quote, Mary Douglas tells us that the kinds of examples that we learn and use tell us about the community of which we are a part, and they are central to shared knowledge that builds our community and our sense of belonging within that community. So yesterday I spent the early morning, this is how I spend my Sunday mornings, I went through an extensive and expanding digital archive reporting on Ebola. There were interviews, news reports, official government and international agency reports like the ones that Kim was clearly scouring for numbers, and tweets and Facebook posts. So I have this large archive, and I went back to the early months of the epidemic, so from April to May. But what I want to focus on today are the kinds of analogies and reference points that we're using in the US to understand the events in West Africa as a way of getting at our deeply shared understanding of the world and how that affects our official responses to the outbreak. I also want to use what I hope is a cultural reference point, or a set of them, to read the epidemic together. So what I want, here are some of the cultural references that rose to the top of the pile for me. The first one was this one, Outbreak. Remember that movie Outbreak? Yeah, Ebola's not really like that. Except it is, because that's kind of what the movie is supposed to be about. There's that piece. And then there's my favorite, the military's mission to fight Ebola might be dangerous, but it won't be Black Hawk Down. Black Hawk Down was our second choice. And then, I forgot my third one was 14th century Venice, which you'll see a little bit more about. So I'll talk a little bit about all of these. This was me yesterday. Black Hawk Down, Outbreak, Venice in the Middle Ages, looking for some better analogies, please. What I didn't show you is all the people who responded with other stuff. I'll talk about what that other stuff is. So on Twitter, this is me being frustrated. And the first 2 examples I want to use Oh, this is the one. This was actually on NPR too. If you listen to NPR, you saw this. So here are the things that came up for me. My outbreak, my Black Hawk Down, and 14th century Venice. So this is what the PPE, the protective gear, looked like in 14th century Venice for historians of science and medicine. And then there's that movie, 1995, Try to Remain Calm, which if anyone knows me, they know that I've seen this movie like 20 times in the past 3 months. So I have a lot to say. So I'll start there with my favorite movie, Outbreak, and so I'll describe a little bit about what happens in that movie because I'm not sure everyone's seen it. Hopefully there won't be any spoilers here. It was made in 1995. You're probably not going to watch it, but it is on HBO on demand. So the film opens in 1967 in a mercenary camp located in the fictional Congolese village of Motaba. Amidst bombs and gunshots, the camera pans over the bodies of sick mercenaries, black and white. And at least one of the 6 soldiers identifies himself as American to Colonel Sam Daniels, who was played by Dustin Hoffman. And he's a military epidemiologist who's been sent to investigate an outbreak of a hemorrhagic fever. So Daniels collects blood samples from those patients, and upon his departure, he tells them, I will be sending you some supplies and some food. So his colleagues, his military colleagues, had something else in mind and dropped a bomb. So everyone runs out, yay, supplies, and the bomb drops, and it kills everyone, wipes out the entire village, and the entire mercenary camp. 30 years later, Colonel Daniels comes back to the same village and discovers that everyone has died. At the same time, we see, I won't talk about the Juju man, but lots of other things happen, and a monkey named Betsy is captured and taken on a boat and smuggled into the US. This is a point where I should show the picture of the Newsweek cover with the chimp, but I won't do that. And so in a Hollywood sleight of hand, this disease, once only transmitted by bodily fluids, becomes airborne and kills, and hundreds of people become ill. The first is a picture of the forest, and then there's the guy, or the pet shop, and then Patrick Dempsey as Jimbo gets it on the plane, then spreads it to a bunch of people, and then the lab guy, and so on and so forth in what I call Hollywood sleight of hand. And hundreds get ill in a movie theater. And so within a short period of time, the US military encircles the town of Cedar Creek. It's a fictional town in California, and it prevents the town's residents from leaving and causes complete hysteria. People loot, people fight the police, all of this stuff happens. But this is where I'm going to start. Bear with me, I'm starting to make the connection here. This is where we don't know anything about Cedar Creek in this movie. We don't know what its history is with military intervention or police violence. But the current events in West Africa show us precisely why history matters. And so, just as Kim was showing us, in West Point, which is an informal settlement in Monrovia, so it's not simply just a community, it is a community of people, of slum dwellers. Those people have, and I read a whole bunch of NGO reports, which are actually fabulous reading if you have that kind of time, but where they talk about how there are rumors in this community about the police coming, or development people clearing those areas, raising those areas and resettling people. So when your community is considered to be a problem, and the police come, or the military comes instead of doctors, you start to wonder. And in fact, that's something that one of our colleagues, a journalist who works in Monrovia, noted. People were saying we were looking for doctors, but what happened was military came. So with this history of dispossession and marginalization, and these unsubstantiated rumors of raising informal settlements, knowing those things helps us to understand how people are interpreting the military and police interventions there. But certainly it intensified existing relations. And in Sierra Leone, a cordon sanitaire, which was around Kenema and Kailahan district, and apparently still is. I heard this, so I was really surprised to hear about all of the people. So during the 3-day lockdown, I heard that lots of people crossed the border because they didn't want to be locked down. So whatever that looks like, it's not working, but what is certainly happening there is people are not able to, in general, not able to move, and they're not accessing goods and services. And the prices have skyrocketed with severely restricted flights and border and port closings. In fact, before the 3-day lockdown, prices went up again because everyone was stockpiling for the weekend. And they weren't really sure that they would stop the lockdown at the end of the 3 days. On Sunday, there was a rumor that they were going to extend it, but that didn't happen. And so what we're talking about, and it's not like that quarantine around that place started the problem. It was the fact that British Airways, Kenya Airways, I think they were one of the last ones to do it, Air France, all of them stopped flying into these places, which is also, as previous people talked about, limits how many people can actually come in. So Outbreak, to get back to that story, while it's not overtly political, I think there's an implicit indictment of Cold War politics in Africa and its consequences, right? Like, why would you take a mainstream blockbuster American movie and put a 1967 mercenary camp as the beginning of the outbreak narrative if you're not trying to make a statement about it? And it's not clear what they were fighting, but because it's in Zaire and because it's 1967, let's just assume that it's about the US government and its role in Congo during decolonization. And most people I talk to about this, especially my students, because I've taught this twice, they don't buy it. They don't think that means anything. They think it's just an interesting plot point. But I actually think there's a little bit more to it than that. But what I want to suggest too is that it provides some information for understanding that all of these interventions, which seem to have a sort of time limitation around them, actually are part of a long and troubled history that extends well to before decolonization and liberation movements. And these become a part of how people understand these seemingly benevolent humanitarian interventions. So it's not simply about the slum raising rumors in West Point. It's not simply about a mistrust of government officials in the recent day, but it's a lot of suspicion that has persisted. I was talking to Liberians in Rhode Island a few weeks ago, and they were talking about Firestone's role in the outbreak in Liberia. And they're saying, how is it that you have this huge plantation and you're not treating all of these people, using all of that space to treat people? How do you have such a great hospital, but you're not treating people? Not to mention the fact that Firestone employees, while on leave, didn't have to come back. And some of them have been voluntarily put on leave. So not evacuated, but this has happened with NGOs and industry from May. People have left. So we're talking about another kind of economic hit, because we have to admit that any NGO, any company that's working is also doing something to sustain and support an economy. Certainly it's a parallel economy, and certainly it's an inflated economy, but it's certainly one that actually affects what can be done and what an economic situation looks like. So as the number of cases and deaths increased exponentially in August, Doctors Without Borders, which had been the primary international responder for months, issued a call for foreign governments to provide military and civilian capabilities to battle the epidemic. Why is this important? MSF considers itself to be neutral, or unaffiliated with military. And so it was a big deal. Everyone put this up. Oh, look, the MSF's asking for military. They kind of forgot the part where MSF said, we want your military medicine, but we don't want your the military part. We don't want the guns. I call it military medicine without military might. They said that military personnel should not be used for quarantine and containment. Is that possible? I don't know. But it became clear on September 16th, our landmark in the US for Obama's commitment to helping with Ebola. We did learn that non-medical solutions were going to be central to the US response. I don't know what 3,000 troops would be if it's not central. Even as many as observers express ambivalence about this. And it's interesting that now that I think about it, 3,000, so many of you know what AFRICOM is, right? It's the African presence, the US African presence. I don't really know what it's supposed to be about. They claim that part of it is about training to do military humanitarianism, but it's also to make sure that there's a military presence in Africa. There are 4,800 AFRICOM troops, so 3,000 of those 4,800 are supposed to be deployed for this. So I think that's showing some kind of commitment. I'm not going to say what I think that commitment is. Should I? Should I? I'm afraid I'm being recorded. So let's say I'll say what people have been asking me on Twitter, but not on my timeline, always in direct message. Do you think this is about what people's perception that Ellen Johnson Sirleaf is going to be overthrown by some other party? Like, that's basically what I've heard. Is this about keeping her in office? That's what everyone wants to know. I don't know the answer to that. I have been pleading ignorance. But I'll also say that some of those direct messages I've been receiving have been saying precisely that. So in this movie, military solutions to this massive public health problem was, I think, a foregone conclusion. It starts with the military, it ends with the military. The military is never a question. It seems like it's a question in our conversations, but it's not even I'm not sure that we ever had an option of doing this in a non-military way. And in the movie, the question for our protagonist, Sam Daniels, was not whether military would be necessary or even desired, but which kind of military response you get. So are we getting the good guys? Are we getting the good guys? That would be Dustin Hoffman. Or are we getting the bad guys? That would be Donald Sutherland and the voice of God, Morgan Freeman. Well, Morgan Freeman kind of switches sides. Again, spoiler alert. So the question when Ebola Matava settles in Cedar Creek is whether whether the U.S. government will bomb them, just like they did the Congolese village 30 years before, or whether they will provide the medicine and save them all. So the good military men thwart the dastardly bad military men with snappy one-liners and appeals to the bomber pilot's humanity. They radio in and say, do you really want to kill those people in Cedar Creek? After all, you're Americans and they're Americans too. You know, it's a Hollywood film. Of course, they don't kill the Cedar Creek people. And I'm assuming that the good military is what's supposed to be showing its face in Liberia right now, right? But we don't know. It could very well be that they are trying to support the president, make sure that she doesn't lose control of her country. So this was one of many responses that I received when just to further hit home the point about the military from September 16th. Obama orders 3,000 troops. I'm assuming that's a typo. Surely you meant doctors rather than troops. And actually, that's a much longer thread too. Everyone goes, oh, why wouldn't they send troops? Yeah, it's outbreak all over again. So I wanted to. So amongst the list of things that people asked me about, or the list that people gave me of alternatives to outbreak, Black Hawk Down, all this was Camus' The Plague. I wanted to read this quote because I think it's an important one, given what the others have said. All I maintain that on this earth are pestilences and there are victims, and it is up to us, so far as possible, not to join forces with the pestilences. I will end there because I think we actually have quite a lot of fodder for discussion. I was going to talk about Venice, but I think we can stop there.
Well, thank you very much to our panelists. I think those were 3 terrific presentations, and we're all much more informed than we were. So I think we'll now take some questions from the audience.
Thanks very much. I wanted to ask about the ZMAP, which a lot of people are talking about as sort of magic drug. That the absence, the key question is to find some drug or My understanding is from reading, a very quick read, is that the key question really is strengthening health systems on the ground, and that where there have been successful treatments, it had nothing to do with ZMAP in particular. I'm concerned, I don't know what the view of the panelists, but I'm concerned that there's a kind of feeling, but let's wait on the production of ZMAP, when apparently this is not the key issue at all. I don't know what the views of the panel may be on this.
So I have a couple of opinions on ZMAP. One is that we should definitely be working to see how it might work, right? To promote, science that can bring it to trials and we can actually see its effectiveness. But that is not for this outbreak, right? So I think that there should be some devotion to it because I don't think Ebola is going away after this. Having said that, I'm generally skeptical of technical solutions in responding to diseases. And that's just because, they're really expensive, they're usually limited in their provision, right? If we think about the provision of highly active antiretroviral therapy after its discovery in the mid-90s, right? You don't see people in African countries getting it till much later. And I could see, just like we've seen in the provision of ZMAP during this outbreak, that it was really prioritized to be given to people from Western countries, right? To Ken Brantley, Nancy Reipel, the Spanish priest whose name I'm forgetting, right? And then they said, we gave the last 3 doses to Liberia and we're out. We don't have any more. And then a British nurse gets sick. And oops, we have some more. Right, it's left over from the Spanish priest who died. So it wasn't like we just made, it's just, I'm skeptical of, I think that if we had a technical solution that could turn into because I'm pro-vaccine, right? My kids are vaccinated, right? So I think that there are technical solutions that can be useful. And I think that Ebola is not going away even once this outbreak is done. And so I think if we could find a technical solution, that would be great. I worry about the equity in providing that technical solution once it's found, and I wonder if that might be derailing us from what we really need to do, and that is, focus on strengthening health systems for the long haul and providing people with care regularly.
Thank you.
Actually, in terms of strengthening healthcare systems, given the fact that the World Bank discouraged social spending in the heydays of structural adjustment. And Liberia and Sierra Leone have gone through serious crisis, civil wars. So that's caused additional damage. Who's going to commit to strengthening these healthcare systems? When in Nigeria, the largest economy in Africa, our healthcare system has been damaged. There's no commitment to any sort of doing anything. I know Nigeria hasn't had a serious crisis. Maybe it's because people are fasting and praying, who knows? Because of elections, there are political leaders in African countries that can go away and go get treated when they get anything. So who's going to commit to spending this money and, provide worthwhile, decent health care to ordinary people?
Okay, would somebody like to answer that?
I can actually say, I wanted to address the question of the post-conflict moment, because when I was there, which happened to be the post-conflict moment, different NGOs actually carved up Sierra Leone and said, okay, it was I used carved up in a way that was talking about both the surgery of it, but also the the colonial moment. And then so they carved up the districts, and then certain NGOs were working in a district to actually build health facility capacity and health worker capacity on the common issues that public health addresses, which is maternal and child health, vaccinations, who knows what men who get into accidents do or whatever, but that's another issue altogether. And so what's shocking to me is, given that investment and given that actual decision to assign each district a health team and a team of NGO whatever, that even with that, nothing completely that could actually address something like this happened. And I think the earlier point about the borderless, the movement across borders is, so while those places seem remote, if you're living in Freetown, Conakry, or Monrovia, those places actually are quite bustling with activity. And one of the key challenges of public health more generally, as an anthropologist who studies the culture of institutions, public health operates along national lines. It can't even compute globality. So whatever this global health thing is, it's all based upon, it's still international health. And it's a tragedy that people living at the intersection of all these places can't actually access decent health care. So those are two unrelated or similarly related points. But
well, just to add on to that, I just heard a radio interview by an anthropologist, a medical anthropologist by the name of James Pfeiffer, and he in fact indicts NGOs because NGOs, as they come into different African countries, they're not coordinated. They're doing very, things on their own, and they suck up a lot of the resources that should actually be going to creating a national health system. And he has an organization where he asks NGOs to sign on to stop taking these measures that are in fact undermining the creation of a national health system. So I think it goes along with that in a sense. There's a question back there?
My name is Margie. I'm a physician and a public health expert, and I will speak specifically to some of the things that you mentioned about Liberia. I was in Liberia all of the month of April and all of the month of August. I have finished my 21 days, so you don't have to be afraid of me. Yesterday made 21 days since I left Liberia. But I have a few questions not questions really, but comments regarding some of what was said about the events in Liberia. And I'd like to address the issue of quarantine in West Point. I was in Liberia as one of the technical committee members of WHO, and also working very closely as the advisor to the incident manager of the response for Ebola in Liberia. Now, the issue of quarantine in West Point, the reason West Point was quarantined was, there are different people with different opinions, but the reason West Point was quarantined was because the commissioner in West Point reported to the Ministry of Health that the residents of West Point were burying their dead on the beach at night, up to the tune of 200 dead people that were infected with Ebola. They were also hiding sick people in their households, and they were also running away when they were considered to be contacts and were being traced. So it was a question of their migration and the fear that they would infect other communities within and around Monrovia. And that's the reason why they were quarantined after a lot of consideration by the government and the Ministry of Health. And let me just give you some information on what happened in West Point. Excuse me. Contrary to the sensational journalism that you have been getting out here, West Point is a community of 70,000 people. It's a slum. It's by the sea. And it has a large population of young people, teenagers, young adults, and by definition, a youth in Liberia is considered anyone under the age of 35. That's according to the National Youth Policy. So you have this whole population of youth in West Point. And what happened after the report to the Ministry of Health that they were burying their dead on the beach and hiding people in their households was that they decided, the West Point community themselves, to set up a holding center in West Point where people who were sick or who had been exposed to the dead would be taken into this holding center while they waited out this 21-day quarantine period. But the agreement they made with the government was that no other residents from anywhere in Liberia would be allowed into West Point, into their holding center. So the day that they brought in the supplies, the food, the mattresses, and all these things to set up the center, there were 36 members of the center. And when they went to do the distribution, they found, the West Point leaders found that there were about 7 or 8 people out of the 36 who had nothing to do with West Point. Some had come as far away as Cape Mount, which is about 2.5 hours away from West Point. And so they kicked the people out. It was mob justice. They threw the people out, including the people from West Point themselves. And what happened thereafter was the very young group of idle people began to loot and remove the things from the center. It is at this point, when they became so belligerent, that the government decided to quarantine West Point. And that's the background of this whole West Point thing. But you asked the question, why is the military there? Well, the president of Liberia requested President Obama to send in help. Whether she said troops or not is up for debate. But President Sirleaf has been having a very hard time in Liberia. The people have been very unhappy with her leadership, and so perhaps, she is feeling, in fact, they told her that if she left the country, they would burn her house down. So she was afraid that, people would become belligerent and that there were discussions about invasions from the border into Liberia because of this whole Ebola thing. Not so much Ebola, but because the people of Liberia have been dissatisfied with the president prior to the epidemic of Ebola. And that's just one more thing I'd like to say. With regard to your question as to how come people are still getting infected, I'll speak specifically about Liberia. People are still getting infected because they are migrating from one place to another. The borders between Liberia, Sierra Leone, and Guinea are porous. It's just an imaginary line. There's a checkpoint here for immigration, but you can just cross the street because you have families living on both sides of the border. So in Liberia specifically, people are migrating from within the communities after they're being infected and going to other communities, traveling to other counties, traveling to other townships, and infecting other people when they have been considered to be contacts.
Well, thank you.
Yeah, so basically, I just wanted to give you that backdrop.
Okay, well, thank you very much. That's quite a bit of information.
So
Please.
I'm really grateful that you're here today and that you shared with us that information. I learned a lot from what you had to share, and I just want to say that it's probably because I was born and raised in California, and I have a little bit of hippie in me, and my response, my thought about, my way of thinking about the world is probably just different, and that is, if people are burying their dead at the beach, if people are hiding sick people, I get that, maybe that should scare us to do something. The way I like to think about it is, why are they burying their dead at the beach? What are we not providing them that's what they're going to do? Why are people hiding sick people, right? What is it about the way we have been providing care to those who are sick that has led them to such a desperate place that they're going to bury dead, that they're not going to give their loved ones the dignified burial that they normally would? Why are people running away when contacts are being traced, right? Is it because we're not actually providing anything to anyone? And so when a lot of people were saying, people don't know what Ebola is, people are saying that all people do go into that hospital is die. They know perfectly well what Ebola is. Everyone who walks into that hospital dies because it's a deadly disease, and we're not really taking good care of people. And so my response, again, the hippie California person in me doesn't think send soldiers because that's going to make things better, right? That's going to maybe contain things, maybe not. My response is, let's give people some care. Let's respect people's lives. Let's value their lives and provide them with something so that they're not going to bury fewer people are going to die. They're not going to bury the dead at sea, right? Their bodies are going to be well taken care of, and they're not going to run away when we think that they're sick because they think we might actually care for them. And so that's probably just a different worldview.
Okay, let's have responses.
I also wanted to, did that.
Their rights, their tradition and culture have a great part to play in this. People in certain communities are accustomed to preparing their dead in a certain way. The people in West Point are seamen, they're fishermen, and a lot of times they do bury their dead at sea. But the situation of them running away and hiding was because they didn't want to be stigmatized as having Ebola. In fact, the slogan in Liberia amongst these populations was that they prefer to have AIDS than to have Ebola.
Thank you. Does someone else on the panel
Well,
want to
say,
respond?
because there's treatment for AIDS. I also wanted to add too that I actually had heard the exact story that you told about West Point, and not only from a reporter who actually was there during the time, but from a friend who's been living in Monrovia and working with that community for 15 years. And so he told the exact same story. So I just wanted to just say that that's precisely still one of the questions that I have, which is how communities that are marginalized still perceive how they perceive military intervention in this kind of setting.
Okay, I'm going to take one more question, sorry, and then I'm going to ask the panel to give any brief summaries that they would like to give, and then I'm going to ask Donald Robotham to make an announcement.
Thank you very much. This was really great. Very informative. So, what I'm wondering if we need to think about this situation in two ways. One is the immediate crisis and emergency response versus the long-term developing the infrastructural response. So when we think about how to respond, is it important to separate out those two different ways of thinking about this? So as you mentioned, Partners in Health earlier, and they do not, Partners in Health, as I understand it, do not claim to be emergency responders. But then because they believe in the long-term developing, working with the public sector, like James Pfeiffer is talking about also, to create the medical infrastructure that people need, working with people in solidarity on the ground in whatever place they're going to. But then they get called in to be emergency responders. And so I just wonder, if you could talk a little bit about the distinction between those two aspects and how we might move forward into the future.
Okay, I think that's a good question to close with. And so I'll ask every member of the panel to address anything else they'd like to address as well.
Well, I just want to address, I think, that question because that's an important one strategically as a response to the outbreak now unfolds, supposedly with more means. And I think in recent days we've seen a great focus on the biomedical aspects of the response, the health systems aspects and the biomedical aspects of the response. Can we get better care in Liberia, in Sierra Leone, and so on and so forth? And that's what Partners in Health, like the rhetoric they come up with has been about, is to say, well, Ebola has never met kind of high-quality modern medicine. And when it does, people survive like the workers who have been repatriated here or evacuated and so on and so forth. But the problem is, can we actually scale up those hospitals fast enough to keep up with the number of cases that are coming? And given that the curves are really shooting way upward now, I don't think that's the case. I mean, I don't think we can just build hospitals, train workers, even if it's 500 a week, like the US response plans to do. I don't think we'll get there fast enough, or at least a lot of people will die in the meantime. And so in the short term, I think there needs to be a lot more emphasis on more behavioral responses. How do you limit your exposure to the virus so that you manage to prevent infections rather than make sure you have the structures in place to take care of them clinically and try and improve survival, like has been the rhetoric of Partners in Health, for example.
And basic supplies, like gloves.
Yeah. But now, I mean, the basic supplies, infections have become so common and so widespread that the basic supplies is typically what we talk about when we talk about infections in healthcare settings. Now, what is going on in the community is a different story altogether. How do you avoid infections in the community? Well, there needs to be a dose of behavior change that is not emphasized enough, I think, in my view at least.
Okay, thank you.
When I gave a talk when we were on a panel about this at Smith, one of the last slides we put up was, what organizations can you donate to? And it was really hard for me to come up with that list because my belief is that though there is this emergency that requires an emergent response, I don't feel comfortable having us focus on only the emergency, because to me the emergency is just a symptom of a bigger problem. And again, this is why I'm really hesitant to be to feel good about my country's current response to the epidemic, even if it was called for, even if MSF said that that's what they wanted, that they wanted the military, and I just think I would lean more to the long-term response of developing the healthcare systems, of recognizing what role the international community has had in shaping the current provision of healthcare in these countries, and for some understanding of how we've been actively discouraging an investment in health. So I came up with a list of who's Partners in Health working with in Sierra Leone and Liberia, right? That because those partners are actually going to invest in the long-term provision of healthcare in remote places, real quality healthcare, and I think that that's important, and I think that they are going to do some things in the current outbreak that are useful.
Thank you.
I don't know if I can address that question because I think both obviously have to be happening because life is going on despite whatever the outbreak looks like. In addition to this outbreak being a sort of symptom of past failures, it's also a diagnostic of how life is valued, right? And one of the things that I think we were all getting at was how this epidemic has shown what that hierarchy looks like, right? Who gets to go in and who gets to come out? Who gets to be treated with a ZMAP, or who gets the experimental treatment, who gets the ICU, right? And so one of the large arguments that I've made about the logic of humanitarianism is that it has a racial logic, it has a national logic. It is premised on some people have the right to come in and come out, and they risk their lives, but only insofar as they want to. When the going gets tough, they get going, right? Not everyone has that privilege to be evacuated. Not everyone has that privilege to seek out care in ways that look like the care that they want to receive. Not everyone gets to escape a crumbling or debilitated health system. But again, this is a diagnostic, and it's something that I'm hoping this allows us to see and address. So,
thank you very much. First, I'll bring in Don Robotham for an announcement. And then we'll thank the panel.
Yeah. Well, first of all, let me thank everybody for coming out to this awkward hour. It's such an important issue, and we really think that we have an obligation for obvious reasons to do everything we can possibly do on this issue. I'm very taken with the point about behavior change, which Stefan raised. I really think there was a film I saw done in Sierra Leone, which was tremendously effective in people acting out roles around Ebola in terms of public education. I just think there are just immense this whole Nollywood industry, there's enormous possibilities in influencing behavior, which are not really being tapped and which really are not high cost when you think about it, right? So, this is an immediate question. I think the challenge is how to deal with some of the immediate issues. So I really think that's so important. But let me just say, we have many reservations, of course, on the charities issue, but I think also people may want to contribute. And we identified this place here. So if you want to contribute, right, you can go to this website. Please write it down. It lists a number of different avenues that you can contribute. And I really think this is very, very, very important that we make some practical, immediate step to do whatever we can, however small it may seem to us and insignificant in the totality of things. I think this is really, really important. I don't know what to say. We have a fire drills coming up at 2:30, I think. I don't know. I thank you very much and everybody. Really.
Okay, well, let's thank the panel, and I think we should leave with the questions on our mind of short-term and long-term. Short-term, very important, but let's keep in mind what the long-term measures must be to deal with the whole social context that has produced epidemics as we see them.
Great, thank you.